Jagger. I'm a child and adult psychiatrist. And today we're going to talk about ADHD. It's going to be a presentation in two parts. Today I really want to focus on diagnosing ADHD and that process. And then the second part, which we're going to do on February 1st, is going to be more focused on the treatment once that diagnosis is solidified. And but I'm going to really break this down into how to do a good assessment and really consider a broad differential and how to really do your interview to kind of tease out symptoms, because obviously seeing ADHD is probably one of the most common things that I see, but it's also something in the world, especially of children, and I think adults, that you'll hear me referred to attention symptoms as sort of a fever of unknown origin. The fever or the symptom is really problematic. It causes functional impairment, but it could have attention problems can have a lot of different causes. And while sort of, if you're a betting person in a child, a lot of times it really is ADHD. It is a condition, though, that often can span several generations. And while people can outgrow it, it has a huge familial influence and genetically inherited, and it also has long-term sort of implications if left untreated. And so it's really, although we often talk about medicines and treatment, it's really critical that the diagnosis be really accurate. I see and have seen a lot of it both ways, where ADHD has been missed early on and really the root of a lot of the other things that present down the road. But I've also seen it misdiagnosed as well. And then sometimes I've seen it be accurately diagnosed, but also people sort of afraid to treat it. And then something else occurs, and then people are confused because oftentimes there are multiple things going on. And so these are all sort of factors to sort of be aware of, but I really want to just really start with that. And I know we have a lot of pediatric providers on here today, but I also think it's important to talk about what do you do if this presents in adulthood, and really sort of understand how some of these things actually change over time. So I know I say this every time, but I really do welcome you to interrupt me if you'd like to add any comments or ask any questions, just really at the point of the interview, because these are really important things. And if you have the question, I'm sure everyone does. So with that introduction, let me share my screen. I'm also going to be sharing some screeners with you that you can use to screen out other psychiatric conditions. And Elizabeth has those, and we'll send them out to you that you can use afterwards, as well as you kind of build a clinical practice. So let's get started. You all see that okay? So as I said, we're going to really talk about what ADHD is, how to really do a good differential, both medically and psychiatrically on causes, and then we're going to save treatment for February 1st. So I sometimes blow over this part when we talk about the criteria because it's something I've memorized, but when you really do a good ADHD assessment, it's really important to understand the reason for all these criteria and to really align it with good clinical care. And so it's important we don't become complacent in this as well. And so we're going to go through each of these, and I'm going to give you some examples, ways to ask questions about it. But you will need at least 6 of these criteria for at least 6 months, and they have to cause functional impairment. And there's a couple things that also really I want to point out here is this is not a short-term condition. Although it is usually present for 6 months, most people have had symptoms persistently. If you truly have ADHD, it's not really something that waxes and wanes. It can wax and wane with cognitive demand or environment, but the symptoms themselves are probably going to be there most days, every day. And so it's not like a mood disorder where you can kind of have remission or relapse. It's a progressive neurodevelopmental condition that really would be there for each day, with maybe its presentation and functionality different at those days, but the symptoms are probably going to be there. And the 6 symptoms can be across a host of 3 clusters of symptoms, and we're going to go through those. It can be hyperactivity symptoms, impulsivity symptoms, or attention and focus symptoms. The symptoms must be present before age 12. And this was a diagnostic change that occurred with DSM-5. It used to be age 7. However, as we talk about the symptoms, the focus symptoms in particular, the attention symptoms, are often much harder to recognize below age 7. And if you think about cognitive development, most people can't really self-report symptoms that they had before age 7 in adults. And so that age 12 was really redefined because it really increased the accuracy of diagnosing. And I'm going to slaughter the statistic, and I don't have the resource off the top of my head, but symptoms that occur only after age 12 with ADHD, 95% of those are unlikely to be ADHD. And that was a big shift. I think it was almost like 60% when it was age 7. But when you went to age 12, symptoms that never appeared before age 12 were 95% not likely to be ADHD and explained by another condition. So if you are meeting an adult going back early on in their early academic history before age 12 is important. Now, there is a caveat to that. Sometimes ADHD symptoms can be secondary to medical causes or other presentations, and especially like head injuries that can cause ADHD symptoms afterwards that we would sort of put in a more unspecified or due to a medical condition category are an exception to that. But true biologically inherited ADHD is pretty rare to have not manifested in some capacity before age 12. Now, functional impairment may be different. And higher IQ individuals may have less impairment from attentional symptoms because they have a lot of skills to correct for them or adapt for them. They may not show up academically, but the symptoms themselves should have been present before age 12 in all settings. The other part I want to pull out is that developmental level. And this is also quite important to recognize that a high degree of developmental disabilities like intellectual disabilities, autism spectrum disorders, and other developmental conditions and genetic syndromes in children also have very high overlaps of ADHD symptoms. And there probably is something biologically different in the presentation and etiology of these symptoms because they do not respond the same to medications. But children are hyper. And so it is important with that developmental level to make sure you separate out children that may be at a lower developmental level for part of their reasoning. And children have to learn by moving and doing. And so if you have a child that might be older, let's say you have a 13-year-old, but maybe cognitively they're presenting more like a 5 or 6-year-old with their learning skills, you may see higher levels of physical activity related to how they're learning if those are the skills that they're learning at. And so you do want to at least correct in some ways for their cognitive level if you're able, but there's very, very high comorbidity of ADHD with many genetic syndromes and other neurodevelopmental disorders as well. You want to make sure it's present in 2 settings. And those settings really mean that this just can't be limited to a behavior problem in the home or one parent endorsing a functional impairment when maybe you aren't seeing other settings. And that's why, especially with kids and with adults, I think it's even more challenging, is you really want to show the level of dysfunction occurring in multiple places, maybe at home, at work, at school, interpersonally, because again, these are not symptoms that just go away. They are persistent, and that's a major difference when we talk about differential diagnoses. While the functional implication of the symptom may be different, the symptom itself is going to be there most days, every day, if untreated. And these do cause significant impairment in social, academic, and occupational functioning. And this is not just simple lack of success or academic achievement. These are usually causing substantial difficulties. And untreated ADHD can really lead to significant psychiatric comorbidities, self-esteem, and things as well. And so it's really important to recognize that. It's also important to recognize that one of the reasons, and we'll talk about this more in treatment, is a lot of the treatments regarding ADHD require or some knowledge of use of stimulant medication. And stimulant medication makes providers and prescribers very nervous to write. And it's important to realize that having increased focus from a stimulant is not diagnostic of ADHD either. And so it's important that we don't think of it as an enhancer, because about 50 to 60% of people that would take a stimulant would probably have some increase in focus at doses, and that is not diagnostic if you have a response to treatment either. And so when we're really talking about impairment, this is noticeable, ongoing, again, some daily impairment that is occurring as a result of those symptoms. Okay. There are 4 categories of ADHD, and we'll talk about those a little bit, but a lot of this depends on, as we go through the criteria, which symptoms they have the most of in the categories. One category is inattentive, and one category is hyperactive impulsive type. The vast majority of ADHD cases have combined type symptoms, and these are felt largely in those first 3 to be a variant of sort of a biologically inherited ADHD pattern, which we'll talk about. There's another kind of category called not otherwise specified that is kind of a free-for-all when the symptoms may not meet threshold but have functional impairment, or the etiology may come from a neurodevelopmental disorder or other sort of secondary cause, such as a head injury, where again the symptoms are present, you might meet criteria. I think about this category for people that have marked ADHD symptoms from like head trauma. I often, although it's not incorrect to give with other ones, I sometimes you'll see prominent ADHD symptoms in children that have been exposed in utero and have had sort of frontal lobe injuries or toxic exposures. And so it can have a lot of different meanings. If you think about the category of symptoms, and we're going to break them down, there is a natural course of how symptoms tend to present in a lot of people, not especially the combined type. Often adults or caregivers or other observers are going to be much more likely to report hyperactivity and impulsive symptoms. It's hard to ignore a child running in circles or climbing a bookcase when the other kids in the classroom are sitting still. And so it is much easier for secondary observers to pick up on these symptoms. It is much harder for people to report inattentive symptoms. And so a lot of times inattentive symptoms have to be obtained by someone that's watching the child really do focused, needed work or reading. It's also important to realize that a lot of inattentive symptoms are missed. And the inattentive symptoms are the ones that can have lots of other diagnostic overlap of reasons why attention problems might occur. And so it's harder. And also as adults progress, and this is why if you're evaluating someone who is an adult with ADHD, those hyperactive symptoms may transition and change. While they may have been a wildly hyperactive child, as an adult, it may be just a feeling of restlessness, of not sitting still, or more like a fidgeting sensation with their legs or feet. It may not be the gross hyperactivity that they have. Traditionally, hyperactivity and impulsive symptoms do begin to decrease often around puberty, when the development of the premotor cortex and some of the additional development of the frontal lobes help take over and suppress some of the motor drives as well. So there is a shift. Some people do not have hyperactive or impulsive symptoms. Some people are strictly inattentive. This used to be called ADD. However, the correct terminology now is ADHD inattentive type if you only have the attention focus symptoms. As I said, most of the time it is a combined type presentation where people are exhibiting symptoms in both categories to some degree. Okay, so let's talk about what the criteria say, how you can screen and ask. And I'll show you some standard questionnaires because especially if you have a pediatric patient, you're trying to elicit information from another caregiver or a school teacher that's not in the room, you're often asking them if they notice these things. But if you're have an adult and you may not have an extra person to ask, or you're trying to ask a spouse or a boss or an employer, sometimes you have to figure out, how do I ask this question? So failing to give close attention to details, making careless mistakes in schoolwork or other activities. And you can just ask it that way. But I tend to really ask people, how often they make mistakes, what's the reason for their mistake. I ask them, first of all, what they do that might require attention. Sometimes you find out that they don't like paying attention or they avoid things that require attention. Sometimes you'll hear the symptoms combine as you're talking about attention, where and one of the things that's pretty well known is if 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 you don't have ADHD and I put you on a treadmill and I ask you to read something, you'll have a harder time reading it. If you have ADHD and I put you on a treadmill and you're exercising, the blood flow that increases to your brain actually improve your chance of paying attention. So sometimes you will hear people describe that their fidgeting activities or their movement activities are actually increasing their ability to focus. So when you're talking about attention, you may be eliciting hyperactivity symptoms that are helping them pay attention. This is sort of where you often learn about like people that look like they're multitasking, but they're actually using things to increase their ability to sustain attention. Sometimes you'll hear people talk about using caffeine, or this is sometimes where untreated ADHD may see use of stimulants off non-prescribed that they're using to kind of, so you wanna figure out how they're coping with their attentional difficulties as well as how frequent it again. And remember, this is a persistent condition. So these are not things like I had a bad night's sleep and for 2 weeks I didn't sleep and I crammed and I couldn't. No, this is an everyday problem that people will say. Every day I forget my car keys. I have to I have to make sure I put them in the exact same place because I will forget where I put them. Um, Difficulty sustaining attention in task or play. It's also really important. You want to find out what they're doing that requires focus. For adults or kids old enough to read, asking about reading is a really important thing to really understand how they read. A lot of folks that have attention problems avoid reading or dislike reading because they often have to read over and over again. They have to break things down into tasks. When I observe kids come in my office, I actually watch them play. Even if they're not hyperactive, the kids that, and you have to see it recurrently, but because in a new environment, when it's like the kid in the candy store and everything's exciting, you'll see people jump around, but you'll see kids not be able to play quietly. They play with things that should be quiet and they're loud, or they literally can't hold their attention. They jump from activity to activity. And so my office would be full of toys and I would bring kids in and I'd see, even with a novel task was really exciting, how long they could stick with it. Or I'd play a game with them, things like Uno or Connect Four that were simple enough at their cognitive level. Could they even follow some basic rules, or did they get so derailed from paying attention that they were off to the next thing? And you could sit there and count how long they could even tolerate something like that, and then compare it to what you would expect in kids that age as another piece of information. Oftentimes the kids are listening, they just miss things. And so a lot of times you'll see secondary symptoms that come out of this, where kids look oppositional or that they're not paying attention, or their parents say they never listen to me or do what I ask, but it actually may be an attention problem. So you'll see parents talk about, well, if I look them right in the eye, or I tap them on their shoulder, or I only give them one step, they can do it. But the moment I give them 2 or 3 things to do, it's all over. They can't remember all the steps. And again, that's coming down to not having the attention to encode multiple pieces of information. And as a result of that, they often don't follow through on complicated commands. And so when we talk about treatment, it's often really important that kids and adults have instructions and tasks given them in multiple ways, like visual, auditory, ways that they can check and double check, because they may not encode all of those information. I ask about organization. Are they messy? How do they do basic organization? How, when they bring their school folders home, what do they look like? Do they forget assignments? And some of these things can help correct some of the symptoms too. If you give them an organizing task, then they can sort of check themselves for what they might miss. Oftentimes, again, they may just not like certain activities. Sometimes kids that are having really significant academic challenges because they can't pay attention end up not liking school. They may be really smart and really good at things, because ADHD is not a disorder of intelligence, but they may really be avoiding things that require focus, or ability to need to do hard tasks. And so I again ask people about their likes and their dislikes, and often what it is that makes them not want to engage. The losing things is really common. This is, again, just not attending to where you put things, misplacing things. I've had adults whose spouse has come in saying every day they forget their keys, or they can't remember to pay the bills on time, or simple sort of executive functioning tasks that they just can't remember to do. Or even if they are doing them well, you can often ask, what is it taking for them to stay that organized? I did an ADHD evaluation on a medical student once who had, by all accounts, really significant ADHD throughout most of the childhood as well, but he was really smart, had made it all the way to medical school, and then was really hitting the wall when he got to medical school. He knew the information, but it was so much information that he was spending hours taking the textbooks that he's supposed to be reading and making flashcards, and was really having to spend so much time to break this complex stuff down into simple things that he could code and memorize instead of understand, because he couldn't handle all the mental tasks to stay organized. So he was sometimes using some of his organizational skills to correct for his attentional ones. Oftentimes people are really distracted by extraneous stimuli. And this kind of means, like, if you go into a room and you're listening to a lecture, let's like school, there's sort of this idea of listening to the teacher is the important person in that room. Your brain should be able to filter out the other noise and know that that's important. But often if you have an attention problem, you can't do that. And so you'll see people get distracted by kids chewing gum. The kid next to them will say something to them, they'll be off. And even in conversation, when you're talking to someone, you'll see people just kind of change the subject, and they'll be like, where was I? And they'll get off task and derailed, even in the room. Now, again, it's not always ADHD, but it's a persistent thing that they have trouble being distracted by other noises, sounds, or visual things in the room. And you'll see that when you're talking to them, that they literally will get derailed, and they'll realize it and need to get back on track, but you'll see it happen. And this can often come also about as being very forgetful. Again, all coming down to this key symptom of really not being able to pay attention as the reason these things are happening. So as you screen for these things and get these examples and these yeses, you also want to make sure, as you do a differential, that's coming down to that key attentional problem. It's not that they're getting distracted because they're depressed, or they're not getting distracted because they're just worrying. It's really coming down to attention being the reason that they didn't code it in the first place. The hyperactive symptoms, again, are often a little bit easier to see. These are the ones, again, that do seem to decrease as you get older. But they can be very fidgety. These are the kids that want to play with the fidget spinners and tap and squirm. I did school observations for a while, and I would see kids rock in their chairs. I saw one kid almost do a headstand on the floor with his feet on the chair. He couldn't sit still. And they just look like they're squirming and moving. They almost look better if you let them stand and walk and not try to contain them in some ways. Sometimes they just can't sit still. They'll get up and go, or they'll get up and move. And this can be part of treatment planning, where you let the kid move around and pass out the papers, or you give them tasks again to get that movement going. Because remember, that movement, that hyperactivity may serve a purpose in increasing blood flow to help correct the attention problem. You'll often see them running, climbing excessively. And again, it's the inappropriate piece that matters. Lots of kids are hyper. They're supposed to be active, but these are kids that are often doing it when no one else their age is doing it, or in situations where they should be able to contain themselves briefly and they really can't. This happens, of course, too, with focus work, but it also happens when they're having fun. They may be the kids that really have trouble modulating their voice or their bodies. And so even when they're relaxed, they're hyper. The younger you are, the more likely you have that significant hyperactivity. But these are the kids that cannot slow down. They run and run and run, they climb and climb, they jump, and they may talk excessively and interrupt you too, because I just can't slow down. That motor control from that frontal lobe is just not there at all. And then impulsivity is sort of the counterpart to the hyperactivity, but this is the problem waiting our turn. And parents will often describe this, and as you get into adult, it's more problems being patient. I just can't wait. I want to say something. I can't withhold it. I'll blurt things out. I'll interrupt you. And sometimes, again, during interviews, you'll see that happening. They just are, it could be excited. They just think they know what you want to hear, and they'll blurt out. They cannot slow themselves down, but it can also come out verbally as well. And again, this was the change that happened in 2013 from DSM-4 to DSM-5, that the age changed. And again, we talked about that, but that age 12 cutoff, having symptoms before age 12, really increases the accuracy of a true biologically inherited ADHD. Even if they're presenting after age 12, you want to go back. So if you're, again, interviewing an adult, a lot of it needs to focus on, tell me about what school was like. Tell me about how you played. If you can get collateral from a parent, a family member, it can also really help, because if it just appeared after age 12, after puberty, it's less likely that it's pure ADHD. And I think that's the take-home point I want you to remember. So this is an incredibly common disorder. And although we talk about how important it is to rule out other causes, at the end of the day, it is still the most common disorder of childhood. And you want to kind of make sure you've ruled it in, ruled the other things out, and you want to make sure you do so early, because most kids, especially the ones with hyperactivity, are going to start showing up when they hit school. So kindergarten, first grade, really important. That being said, it's also important to remember that developmental piece, because diagnosing ADHD in kindergartners has come down to birthdays. And so kids that were born the youngest in the class in kindergarten are going to naturally have a higher hyperactivity level than the ones born and the oldest in kindergarten. And even that 1 year can really increase ADHD. But once you get to first and second grade, really good teachers that have seen that big spectrum, you can really start differentiating that out. There's kind of a rule of threes in terms of longitudinal thoughts, but there is some decline in the diagnostic rate of ADHD into adulthood. There are reports that up to maybe about a third to half of ADHD from childhood that was well diagnosed will go away in adulthood. And then again, that's related to the ongoing development of the frontal lobes, where a lot of the etiology, executive function controls continuing to improve. So not all children with ADHD will go on to be adults with ADHD, but about 50% to a third may still do so. So it is something to be aware of. And again, if an adult is presenting with ADHD symptoms without a childhood diagnosis, you really want to go back and see, was it missed? Because it may have been missed, but also make sure it's not something else. And you'll just see some frequency reports here. This is, especially in a psychiatric clinic, these are much higher rates than most other illnesses. Okay, so we'll talk about the etiology a little bit, but ADHD as a truly biological form of ADHD, and when I say biological form, that's usually this idea that it was likely inherited, and it was likely a frontal lobe condition related to sort of dopamine transport. And there has been some genetic links looking at rates of dopamine transporters and how dopamine is released into the synapses at different rates. When we talk about the medicines, and that's how it works, that's a really inheritable form. Now, not all ADHD is from that, but that's the type that's most studied. The challenges, we're going to talk about that. There's no test for ADHD to know or not know if it's biologically inherited or secondary to something else, but asking about family history is really helpful. And sincerely, if both parents had ADHD, were treated as kids, if you've seen every sibling, and the 5-year-old comes in as hyper as the other ones were, it's a really high likelihood that it may have been genetically inherited. It's one of the more heritable psychiatric conditions. Again, if it's the biological type, because we're talking about receptor neuron synapse level heritability factors for that type of ADHD. And the reason we want to identify it and treat it is because untreated ADHD, and I could spend a lot of time talking about this, but untreated ADHD carries a lot of risks. One is if you don't have your ADHD identified as an attention problem or an impulse control problem, then you are at risk to develop behavior problems, or people to view you as only having a behavioral problem. And you'll see kids get labeled with oppositional defiant disorder or conduct disorder, which are pretty substantial behavioral disorders, but oftentimes they're rooted in untreated ADHD. And we generally talk about that you can have a child present with fairly oppositional behavior problems and comorbid ADHD. If you really treat the ADHD adequately, about half of those behavior problems will go away. Not all of the behavior problems will go away and may need a different type of treatment than just ADHD, and often need therapy or parent management training, but a lot of them will. And probably that's because the child didn't really have a behavior problem. They had untreated ADHD that was an intention and hyperactive and impulse control problem that was manifesting that way. But it does increase the risk for full development of those disorders if it goes untreated. If you're having trouble paying attention and focusing, if you're having trouble sitting still, there can be social things that you notice about being different from other kids. If you're the kid that gets yelled at by the teacher to sit still or pay attention all the time, it can really impact your self-esteem. And kids with untreated ADHD are at risk of depression and anxiety disorders as well. There also is I didn't list this, but there's a substantial increased risk for suicidal thoughts in people who have untreated ADHD and impulse control disorders. In fact, if you look at causes of suicidality in pediatrics, it's usually not depression. The two top diagnoses are ADHD or disorders of impulse control and substance use. And so although we tend to think of suicidality as a mood disorder, it's really prominent risk of it with untreated ADHD as well. And certainly if you can't pay attention and focus, you can't encode that new information, you may develop secondary learning problems, secondary to attention problems, and not being able to sit still and learn. So this is a really important thing to sort of tease out. And if ADHD is present, treating it may improve those other conditions, and we'll talk about understanding the timing of those things though. So how does this untreated ADHD cause functional problems? Well, there are a lot of studies about the risk of untreated ADHD. If you're super hyperactive, you're klutzy, you're tripping over yourself, there is a known increase in ER visits. This can be related directly to accidents, broken bones, tripping injuries, just results of sort of that impulse control physically with your body. But again, we're seeing a lot more increase in suicidality as well from that impulsive. And I say that if you're impulsive physically, but ADHD means when you're impulsive, you also have impulsive problems controlling your mood. You don't have that frontal lobe regulation to control your emotions. So you'll see significant mood swings and irritability symptoms with ADHD as well. That can be from the ADHD itself. Adolescents who are driving, especially in the late afternoon or evening, often when their stimulant medicine may have even worn off, even if they were treated, maybe an increased risk of getting in an accident from not paying attention. Untreated ADHD really has substantial risks of substance use. Again, this is something to talk about more, but the stimulant medication that treats ADHD, there's actually, although people are afraid of stimulants as a disorder of being abused in its own right, treating ADHD before puberty with stimulants actually decreases the risk of substance use. But if ADHD is left untreated after puberty, it has its own independent risk for substance use development. And again, some people hypothesize this is sort of a self-treatment sort of phenomenon, but it can be quite high. And then the criminal behaviors, higher rates of criminality may be related to the substance use, could also be related to lack of educational attainment. There are several reports about interpersonal difficulties related to ADHD. And I say we think about ADHD in terms of school and work functionally, but if you can't pay attention to the people that love you, it can be very frustrating. And adults will often get frustrated with their partners and spouses that have ADHD because they aren't paying attention and they don't seem to be listening, or they're misplacing things and causing frustration within the family structure that might be secondary to untreated ADHD. And so there are higher rates of divorce and relationship difficulties reported from untreated ADHD as well. Certainly work and school difficulties, not meeting your full intellectual potential, and then again, less educational attainment from untreated ADHD, and the economic consequences that might come from that. And again, this is pretty profound because ADHD is not a diagnosis of intelligence. There are people with very high IQs, very intelligent people that have ADHD, and they can still have substantial impairment in executive functioning, that organization, planning, ability to control emotions, feelings, that are really important to recognize. So as you identify those symptoms, asking people, how do these symptoms affect your day-to-day life? How do they affect your relationships? How do they affect work and school? And I saw mostly kids, but I would say with adults, often I would hear these complaints from partners, spouses, or even sometimes people would bring their bosses in to sort of talk about the challenges that they might be having. All right, so we talked about this a little bit early on, but this idea of the biological etiology of ADHD was really, if it's that genetically inherited receptor level problem, there is not going to be any gross or structural problems in the brain. That means if you did a CT of the brain or an MRI of the brain, they're going to look normal. And this is something that I think is sometimes frustrating. I'll have parents come in, there's something's wrong with their brain. Can you just scan their brain? Well, no, their neuro exam's completely normal. You're not going to see it on a scan. And I tell people, when you're thinking about biological ADHD, if it's happening at the receptor and the neuron level, that's like the microscopic level. Those CT MRIs are like the big picture of the brain, and they're going to look normal. And again, it's because that the root of that is probably this adrenergic or dopamine dysfunction that's occurring. You not have enough dopamine or norepinephrine getting through to the postsynaptic neurons. It could be related to blood flow to the frontal lobes. We talked about that the frontal lobe is sort of where executive function and this is housed, that there could be hyperperfusion. And there are things that can add to that. So I do a whole lecture on substance, in utero substance exposure and how that can cause like prenatal toxins. We can talk about ACEs, which are adverse childhood events or prematurity, all of those things that don't allow the full development of the frontal lobe, or stressful situations that increase cortisol. Cortisol is a stress hormone. The cortisol is toxic to those frontal lobes as well. And so you can see kids with profound trauma. You can see kids with substantial stress or abuse, or even in utero, high levels of cortisol in pregnant moms can really be detrimental to the neurons in the frontal lobes. And so this is a very biologically sort of influenced sort of thing. The reason I bring this up, that noradrenergic dopamine dysfunction, that biologically inherited, where you have the strong family history, that's the kind that's most likely going to respond to medicines. And we'll talk about that next time. But the response to medicines, if you have a poorly formed frontal lobe because you've had destruction of those neurons, the medicine response might be quite different if the neurons aren't there in the first place versus just if it's at that level. And we'll talk about that more next time. So what are some of the other risk factors? Well, we do know that there's some risk factors, but again, the clear cause of ADHD and some of the patterns have been that familial genetic links to dopamine transporters and receptor response. But other things in the environment that again increase stress or affect things can also be quite noteworthy. So again, anything that's stressful, from family discord to parental illness or even physical illness that increases that cortisol response. A lot of kids with foster care that have had comorbid trauma or placement or attachment problems in high stress environments also may have some symptoms of ADHD secondary to those things. If there's been exposure to alcohol, prematurity, lead can be a huge issue. I didn't add this up here, but obstructive sleep apnea, where you're actually like lacking oxygen at periods and not getting a successful night's sleep, can really end up looking like ADHD too. When kids don't sleep, they get hyper, and that is something to remember. I always screen kids for obstructive sleep apnea and snoring when they come for presentations, because anything that makes them not sleep adequately, they don't get tired like adults, they get hyper and agitated. And so it's important we think about that too. Lack of good prenatal care, and again, exposures and fetal stress can all sort of, again, increase the impact of hormones and environmental effects on those frontal lobes and lead to some symptoms. And some kids have multiple insults that are leading to that. And so it's not uncommon to sometimes see that as you've done a good evaluation that all those things may be present. And while you want to make sure it's accurate, you want to understand it in its context. And there are a lot of kids that have really bad ADHD symptoms and they have PTSD, and they may not be mutually exclusive, depending on the timing. So as we talk about really solidifying the diagnosis, it's really important that as a clinician and you have a process, because it's really important to do good quality, thorough assessments, getting as much information as you can from caregivers, from the environment, from the child itself, from your own observations, ways you can structure your office to observe things in the room with you that require attention can really add to that description. We get a lot of information from kids, from parents. It is harder, I think, when an adult presents by themselves. I always encourage or try to get other people in the environment when I'm working with adults, especially if they've never had a past diagnosis. If it's just the adult, I spend a lot of time going back and getting information from what they can remember when they were younger. It's important we don't base it all though on grades. There's a lot of intelligent people that do very well, and those are sometimes the hardest. It's easy enough when the child can't learn to read because they can't sit still. There's a lot of people that are quite intelligent that have just learned how to sort of come up with these hacks to fix their attention that still may be really struggling beyond that. Behavioral issues need to be teased out to really, again, look for, is that a child truly being oppositional and not wanting to listen? Or is the underlying theme in all this that they can't pay attention? And I will sometimes ask parents that very directly. Do you get the sense that your child's purposely ignoring you? Do you think they hear you and they just are like clearly not doing it? Or do you notice if you only tell them one thing, it gets done, but if you tell them three, they can't remember? Or I'll tell parents, well, why don't you go try it? Give them one thing at a time, make sure they like say it back to you, and then see if they do it. As opposed to giving them 3 tasks and see. Or I say, if the kid didn't do it, ask them if they remember what you asked them. And then the parents will come back, no, they really didn't pay attention to anything, and I just thought they were ignoring me. So you really want to help tease that out with the parents and utilize them as your extra information when it's not clear. There's a lot of rating scales that we can talk about. That's really helpful, especially helping teachers communicate to you. I know sometimes it's hard to get information from the schools. Most of the kids that got to see me, if I called, the teacher wanted to talk to me right away. So it was enough that I'd had teachers stop their classes to come talk to me sometimes when I called the school. But there are easy ways to help get information from teachers so that you can both monitor response, but also make the diagnosis. Medical assessments, again, ruling out those medical causes. Could there have been lead exposure? Could there have been sleep apnea? Is this child drinking so much caffeine they're not sleeping? All of those things really matter. The other thing, and I want to talk about this sort of very briefly because There is not a test for ADHD. If you get a good neuropsychological evaluation, and neuropsych testing is different than just psychological testing that has really good executive functioning, you may pick it up. And if it picks it up, fabulous. But there's a lot of people that are going to have normal testing results, but still have ADHD. So you cannot rely just on a single test, because a psychological evaluation is just a point in time camera assessment of how their attention and focus was that day. And again, this is something you want to look over time, because it should be there all the time. So again, brain imaging, not particularly helpful. Routine lab work, not very helpful unless you're looking for a medical cause, such as something like lead, or if you think this child has an undiagnosed genetic condition, or you suspect an intellectual disability that's maybe not been caught, or a genetic syndrome that may be adding to that. Because remember, ADHD can present as a developmental finding in someone with another neurodevelopmental condition. There's not a lot of routine things. Routine EKGs are also not necessary. We'll talk about this more when we talk about medicines, but because the stimulants can increase heart rate and blood pressure, there's a small risk in people that have risk factors for sudden death and cardio hypertrophy that it might be worth screening, but again, not completely necessary as a routine thing. One of the things that is worth sort of asking about is the idea of staring spells or absence seizures. Can sometimes look at like inattention. And so if there's concern of recurrent like losing time sort of things, that may warrant an EEG or to assess that. But that requires, again, as you do your history, it's usually not always been there. The timing's a little different. And also during the spells, it's not an attentional problem. People will actually describe they're like checked out and they can't respond to you. Versus if it's attention, if you tell the parent to use an attention getting technique, often the child will pay attention, but that doesn't work when there's concern about these sort of staring seizures. Okay, so this is probably the most important part of this is what else? Remember, this is a fever of unknown origin. What else do I need to think about? And if you can rule out three main things, or four main things, at this short little list here, you will be successful. But trauma, usually what I mean is psychological trauma, PTSD, with people are actively having flashbacks or feel unsafe, and it's an active symptom because they feel so uncomfortable or they fear so fearful for their safety. That can really in the moment look like ADHD. Again, it's unusual for people to feel that heightened trauma across all environments, and so you may see that depend on where they are. So if a child feels completely safe at home and has no ADHD symptoms, and the ADHD symptoms only exist at school when they're terrified and feel threatened, that is probably trauma. But if, again, you have to separate out the timing, the duration, and the functional effects of all of these. If it's ADHD, it's going, those key symptoms of hyperactivity, impulsivity, and attention are going to be persistent every day, with a function changing based on demand. Things like trauma, depression, anxiety are much more episodic, where the symptoms much more flare in episodes or environmentally. So you want to kind of tease those things out. I'm going to show you some screeners. This is what Elizabeth's going to send you afterwards. These were developed sort of with the WVU pediatricians. So when the kids were coming into the clinics, they had gotten a good screen of depression, anxiety, and substance use to compare, so they could help use their time with the kid in the room, teasing it out. And so I know I'm running out of time, but let me.
No worries. And we do have some chats in there too, Dr. Schumacher.
Let me show you real quick some of these screeners. And most of these are free. So I've tried to share with you free ones. The one on the bottom is not exactly free, but we're going to be using the Echo Educational 10% rule about that. So there are lots of rating scales. I think if you're going to use a rating scale, get comfortable with one and use it well. So you know how it works. But these are the Vanderbilt ones. These are really good at getting ADHD symptoms. So these will rule in ADHD pretty well. They're scoreable. They can also be used to track. So if the kid's on medication and having lots of ADHD symptoms, that can tell you probably need to adjust them. But there's a teacher form for these and there's a parent form. And they're mostly better for ADHD and like oppositional behavioral things. They do have a few questions on there about mood symptoms and learning symptoms. But if you're going to use a Vanderbilt, this is really to track the ADHD, to rule the ADHD in and get those symptoms. And you can score it, and there's instructions, and you can compare the parents and the teacher and score them and get ratings. On those, there's a follow-up that's shorter, so you can see if they've had improvement. And there's instructions on how to score these in here. So those are the ADHD rule in ones. But again, these are mostly looking at oppositional behavior, ADHD, some conduct disordered symptoms. There's a little bit of screeners for anxiety and depression in there. I do not think the Vanderbilt is good for ruling other things out. So if you rule the ADHD in with the Vanderbilts, make sure you do a little bit more for the other ones. And so anxiety and anxiety screeners have become a really big thing and really important in the world of children lately because of much higher rates of anxiety. These are free and online. These are the scared forms. There's a child form, and I really like the child form because it gives children, usually best age 7 and up, a chance to kind of self-report their feelings. And these may be things they don't always verbalize very well. And so giving them a way to sort of gauge it on paper can be really helpful for kids to put words with their feelings. And so this is a screen for kids with anxiety. At the bottom, again, you can score it and see if it flags in all the different anxiety categories. And there's a parent version as well. And then this is for 11 and up for depression. This is the Columbia depression screen that can help you kind of rule in or rule out depressive symptoms. I did not give a trauma screener on here. There are some quick trauma screeners you can utilize. The challenge sometimes with the trauma screeners is that you have to have a lot of rapport with the child to get them to answer about that. And let me see if I can, the other one I wanted to show you is substance use. I've seen kids as young as 10 abusing substances, even though that's hard to kind of believe. But you really want to build in a way you can ask kids about substance use. Oftentimes, again, as a lot of the substance use may be secondary to untreated ADHD, but this is one of the things I saw a lot of during the pandemic. Had a lot of kids come in that have been vaping and using marijuana, complaining of concentration and focus problems, and we're having trouble at school. They were smoking marijuana every day. If you're smoking marijuana every day, you're gonna have an attention and focus problem. You may still have ADHD, but it's really important to know. And I would say, especially in that older 12 group, making sure you've ruled out a new substance use disorder, and you need to have a lot of privacy and protections for the child to give you an honest answer. But this is one of the most validated screeners for substance use, and it asks some very specific questions. It's the CRAFT, and it's this acronym of asking kids. And it's about the functional impairment of the substances, not just if you do drugs you're bad, but are you really starting to have some problems from doing substances? Like, are you riding in a car? Are you using substances to feel better? Are you using substances alone? Are you forgetting things? Are your family and friends where you're getting into trouble? Really starting to think maybe this is a substance use problem. If you get 2 of these as yeses, that's considered a positive screen and pretty high risk for substance use. So we tried to build those, and the way it worked in the clinic was the folks would get those screeners. The kid could fill them out kind of privately while the parent was getting interviewed around the ADHD, and then they kind of meet with the child separately and have a lot of information. So you can both rule ADHD in, but really screen for the other things that might be going on. And in some kids, there were multiple diagnoses going on. And so it was important to kind of know that. But if you think multiple things are going on, which you got to go back and go back through that timeline. Well, which came first? Did the anxiety come because you were nervous about school because you couldn't pay attention? Or did the depression come because you felt self-esteem problems? Or did the attention problems come because you were depressed after the fact? And so really trying to get that timeline is really, really helpful. All right, I got 2 minutes. I said there were some questions in the things. The executive functioning is kind of the fancy term for ADHD. So executive functioning is the frontal lobe effects of planning and organizing. And by definition, ADHD is a disorder of executive functioning, if that sort of helps. You can have executive functioning problems from other things, like depression or anxiety or sleep deprivation can cause that, but ADHD inherently, those core problems with attention, impulse control directly impact executive function. So they're kind of used interchangeably. Very, very heritable. Yeah, and Teresa's right. Make sure you make it easy to get those rating scales back, like stamped envelopes, write the kid's name on that. Sometimes I'd mail them to the school directly or fax them to the school so no one would lose them. And then you got to remember to ask for them and make sure you hunt them down. But yeah, it really, and it's life-changing to make this diagnosis correctly and treat someone. This can really change and improve someone's life so much. And regardless of what time they present, but you want to have a system, you want to feel confident in ruling in and ruling out. And then we'll talk about the medicine and we'll have some therapy things we can add in as well the next time.
Excellent job. Thank you so much. That was really informative, and I didn't know that much about it. And I just feel like sometimes it wasn't talked about enough. When I was younger, what you said, mentioning, somebody might not feel they're intelligent, but they truly are. It's just they have the symptoms and this disease that they need to correct to be able to be their best self. So thank you so much. Does anybody have any questions or comments? And Teresa, do you need any other questions answered or want to expand on any of what you said?
As a former special educator, one of the things that I found that was always, it's like, oh, you should probably go see your doctor, is when the kids didn't like to write. It's not that they didn't have wonderful ideas for stories and whatever, and they could tell you the answer to a question, but to have them write it down, their brains move faster than they're able to keep up with their pencil. And so that was always very indicative for me as an educator of trying to find some other way for the kid to prove that they knew what they knew, because they couldn't get it out fast enough, and it frustrated them, and they're like, I'm done.
No, that's an excellent point, because again, so much of that is connected to sort of motor processing. When you talk about sort of treatments, while the medicine may help, things like learning handwriting or physical outlets or other sort of ways in OT to problem solve, like pencil grips and ways to slow down and do specific like functional daily tasks can really be helpful. And some people really learn some of these things on their own and become experts on them with or without. But that's again just an excellent sort of description of motor hyperactivity, right? You're writing so fast, you're moving so fast, you can't keep up with it. And that is very, very, very true.
Thank you so much for that. Does anybody else have any further questions or comments before our closing? All right, well, I'm so happy to see you all today. And I just have that single announcement. Our next session is January 18th on family treatments with Dr. Lillard. And we will see you then. Thank you.
Thanks, everyone. Thanks, Dr. Swager.